Actually, there are three of them. I want to introduce one of them, and then he's going to introduce the others. But Dr. Cornelius Steelink is a professor of chemistry here at the University of Arizona. He's a professor emeritus, and he's been doing research for a number of years now on the characterization of organic pollutants in the drinking water. Now, in the old flyers that you may have received in the mail, Dr. John Lee was going to speak on fluoride. He had his wife is recovering from surgery, and she was not well enough for him to travel, so a while back he had told me about Dr. Steelink's work, and I was delighted to find that he has some very, very interesting published research, and he's based right here at the university. And so he's going to share that research with you along with his other two collaborators. And so I would like to offer a warm welcome to Dr. Cornelius Steelink.
I'd like to thank Dr. Fisher and the IAOMT for inviting me here. But first I'd like to introduce you to the important members of our team who did the research work. I'd like to introduce you to Jane Circa, nurse, and Tim Jones, Department of Anthropology, over there. Yeah, would you tell me, is it too loud, not loud? How about it? Can you hear me? Is it working? Shall I put it in my ear? No. 1, 2, 3, 4, 5, 6, tooth, dentistry, okay. Is it okay? Yeah. All right, okay. The title of this talk is the Epidemiological Evaluation of Municipal Fluoridation and Tooth Decay in Tucson, which is not related to the title on your program, and I apologize for that. We have a two-part talk. First is a history of my introduction into the epidemiology and politics of municipal fluoridation. And second part of the talk, which will be given by Tim Jones of the Department of Anthropology, is a description of a unique epidemiological study of the causes of tooth decay in children. Both parts of the talk involve epidemiological methods, and I use our experience in this research study whenever I talk to medical or engineering or science or environmental students at the university. Epidemiological correlations, and you've seen some already this morning in Dr. Garowal's talk, epidemiological correlations provide marvelous clues and reveal important relationships. But they also can be oversimplistic and misleading if they're not rigorously applied. And I tell my students, if they wish to use this method, that they first need to develop skills to evaluate data, and secondly, they need the ability to gather meaningful data. Now, epidemiology is used widely to track causes of health problems and to guide research into specific areas. And we hear about them every day. And you have certainly heard about the epidemiology today correlating antioxidants with cancer prevention. Now, how did I, as a chemist, ever get into this area? My own field of research for the past 25 years has been the study of humic acid in soil and water, and that's a classic agricultural chemical field. Now, I got into the field of epidemiology through bladder cancer. In 1974, an epidemiological survey of New Orleans showed certain populations with high rates of bladder cancer. This was correlated, began through an epidemiological study, this was correlated to high concentrations of chloroform in the water that these people were drinking. That particular finding caused the passage in the U.S. Congress, the 1974 Safe Drinking Water Act. One scientific finding caused that. Where did the chloroform come from that these people were drinking? There was no obvious spillage or dumpage. Nobody was dumping, and no industry was around. Where did it come from? In 1976, I and another scientist were at a Gordon conference, and we made the proposal that the chloroform came from the interaction of chlorine, a disinfectant, with humic acid, a natural material. So what is the real cause of bladder cancer in drinking water? Chloroform, chlorine, or humic acid? So we have now three culprits. Well, this is just to illustrate how epidemiology, which may correlate something very obvious, has other implications which you never thought of. And to show you how a chemist can get distracted is to indicate a study of epidemiology. Anyway, I'll tell you how I got into the great fluoridation debate and the history of my involvement and the history of our subsequent studies. For over 100 years, this city, the city of Tucson, has derived its sole water supply from deep wells. It is the best water in the world. And if you have any doubts, ask any citizen of Tucson. The water has never been treated. In the recent years, a tiny bit of chlorine has been put in the water, 0.2 parts per million. In 1991, the city of Tucson announced it would begin using Central Arizona Project water. That is Colorado water imported from the Colorado River by canal. And this water would be treated in one central treatment plant. And all the wells would be shut down. Okay, this is just a brief picture. Here's the canal which comes down from the north and comes into Tucson. And here's a picture of the city of Tucson. The treatment plant would be about right here. It sits high enough that water can go all over the city by gravity. Okay, now the city fathers and mothers said, well, now we can start treating the water. We can put all these chemicals in one place and give those wonderful chemicals to all the people in Tucson. And here is what they put into the water in 1992. Now we're going to have slides for the rest of the talk, so we can get all these chemicals are what we call treatment chemicals. The chemicals below, called disinfection chemicals, are to kill pathogens in the water. Those of you who are visitors, not to worry. We're back on well water. Those of you who live in other cities have already been drinking this all your life. You just didn't know it. Now, chemicals then in a central treatment plant can be put in uniformly and very cheaply, instead of essentially putting chemicals in every well. And there were 200 wells in the city of Tucson. Well, immediately when the city announced this, a lobbying group from the American Dental Association and the U.S. Public Health Service and the Arizona State Department of Public Health started a campaign to put fluoride in the treatment plant and in the drinking water. At that time, I was a member of the Citizens Water Advisory Committee to the Mayor and City Council. And this citizens group advised the council on all water matters. And I was the token chemist on this 15-panel group, 15-member group. I was asked to chair a committee to make recommendations on the benefits, risks, and costs of municipal fluoridation. My committee consisted of 7 members and 2 staff people, including hydrologists, nurses, engineers, public policy experts, and others. We began to hold a series of public hearings on this matter. We were overwhelmed with literature and stunned at the intensity of the pro and anti-fluoridation advocates. It had the same flavor as gun control arguments and abortion arguments. And so, unsuspectingly, we were involved in what I called the great fluoridation debate. And we were lobbied intensely by people who thought that fluoride was a panacea. Whoops, pressed the wrong button here. Those who believed in the tooth fairy, and those who thought that fluoride was the work of Satan. And at the end of 2 months, each of us had accumulated 5 kilograms of written material. For those of you who are not used to kilograms, that's 12 pounds. Anyway, as you all know, most of the documents given to us by both sides of this debate were based on epidemiological data. You know, there's so many children with so many tooth decays live in this town, and so many children with so much tooth decay live in this town, and they compared that sort of data. Or so many people who drank fluoride in this town had so much cancer, and so many people who drank fluoride in this town had less cancer. And every day I was approached by someone from one side of this issue or the other who would come up to me and say, Dr. Steelink, read this and you'll be convinced of the truthfulness of our argument. One day, I received a person from the pro-fluoridation group and one person from the anti-fluoridation group. And they gave me this article and they said, read this and you'll be convinced. It was the same article, I mean identical. Well, I mentioned this at our next public hearing, which was a large audience like you are. I mentioned this and as a humorous incident and said, I expect this is like a religious argument. One can quote the same Bible for any side of the fluoride argument. Immediately, a woman arose in the audience and she says, that's right, Sonny, right here I have the Bible, and it says here, for behold, a bitter fountain cannot produce good water. James 5:11. For those of you who are Mormons, you'll find it in Moroni 17:11 too. But anyway. We received, of course, other types of arguments, and some of them were put out by groups from outside the city. One claimed one of the cures of fluoride. Whoops, sorry about that. I've got the wrong slide. I'll come back. Anyway, our committee concluded that both the claims of benefits and toxicity were based on flawed and uneven epidemiology. I want to just indicate a couple of facts for you here about fluoride levels in drinking water, most of which you probably already know. One, the EPA limit, one, the public health limit, and one, the 1 parts per million, which in general the public health limit for moderate climates. And then number 4, the recommended level of fluoride for children in Tucson in the drinking water. Because it's warm here, the limit is low. Now, in Tucson, we have 200 wells pumping water, but they're pumping different quality of water from different aquifers. A certain part of Tucson pumps water with 8.8 parts per million of fluoride, others part 0.2, and the average is 0.4. The level of water in the Colorado River, which we were going to import and didn't, is 0.4. So those are just some facts. Again, I said we had all sorts of arguments, including one which I just keep for sake of record, that even dental research institutes have interesting data on tooth decay. This Princeton Research Institute received a $1 million grant, and they came out with a conclusion that chocolate does prevent tooth decay, and believe it or not, it was funded by the M&M company. But well, we pointed out in our report to the City Council that there had been a dramatic increase in the ingestion of fluoride from dietary sources, and this made it almost impossible to assess fluoride ingestion quantitatively. No meaningful conclusions as to benefit and risk could be drawn from this mountain of printed material. And we were ready to present this report to the City Council, saying, look, we can't make any assessment because the data are not good. On our panel was a hydrologist, and he pointed out that Tucson had a unique hydrological basin. Wells in certain part of the city produced different levels of fluoride from other parts. He also pointed out that we had been given a database, a tooth decay database, for 26,000 elementary school children, all living in one city. Now that's a big database. It would be possible, he said, to relate tooth decay to the level of fluoride in the children's drinking water and actually determine the effectiveness of municipal fluoridation right here in Tucson. In other words, nature had provided us with a great database. Our own historical records went back many years. Now, I've already shown you a map of Tucson, but maybe if you don't remember it, here again is a map. The numbers here just represent political districts. But the blue area is the area where you have the highest fluoride coming from the well, around 1 part per million. As you go away from that area, out here it gets less, up north it gets less, down to about 0.2 parts per million. So there is quite a variation in fluoride. So we said, well, why don't we just essentially plot the levels of fluoride and plot them against tooth decay. And we did. And you notice that here is the percentage of children with tooth decay in the schools, and here is the amount of fluoride in their drinking water. And you notice as they drink more fluoride, you get more decay. Well, one other thing we did that we chose some selective some selective schools out of this group with high populations to make the database good. And we got another, this is just with the schools identified. The same sort of slope. And if you notice, if you can pick out these schools here, right here, if you picked them out and went back and related them to where they were, they're all down here. Well, As you can imagine, the public health officials were furious with this graph. And they said, you can't just relate tooth decay to one item. That's ridiculous. Tooth decay is due to a lot of things, which we already had said. You know, all these items causes of tooth decay in low-income children, and I don't have to tell you any of this. Any one of these items, or all of them, or even more of the items that cause tooth decay, we had just used the graph to point out that simple fact that you can't relate one item and say that's the cause or the prevention of anything. It just so happened that was a very interesting graph. It wasn't interesting to the public health people. The anti-fluoridation people, of course, they put it up next to a picture of the Bible. But, well, one of the major causes of tooth decay, which I added on my own, since I was involved finally, and I was sort of the target of all this, and there's one other cause of tooth decay in Tucson. It couldn't help in any other city, and that's jurisdictional politics. It would take me an hour for you to explain that, but maybe in your own cities you have politics too. I'm not sure. It's a very sobering thing, incidentally, for a scientist to suddenly realize, and I was very naive, that for the most part, governing bodies are not interested in a scientific approach to things. Anyway, our subcommittee reported our recommendations to the City Council, and these recommendations were later substantiated by a 1993 report of the National Research Council on the toxicology of ingested fluoride, and later in that year by the U.S. Public Health Service in an article entitled "Forward Toward Improving the Oral Health of Americans." However, the City Council, in deference to some of their political objectives, voted to fluoridate the Central Arizona Project water as soon as the treatment engineering was completed. Now, my involvement in this issue was sobered by the realization that the entire issue was political rather than scientific. In addition, it was unidimensional. Tooth decay was only related to one thing and nothing else, either for it or against it. And I was curious at that point of what other factors were related to tooth decay. What other factors? And more to the point, what data were available to explore those factors in a single large population, not scattered, in one population. I didn't have the answers, but Tim Jones did, and he's going to tell you that second part. Thank you.
Sorry about this. I'll put it on there. Now for something somewhat different, but right in the same line. I'm actually an archaeologist. You're probably wondering, what in the world's an archaeologist doing here? That's our first part of our explanation. So we're going to take a step back, figure out what I'm doing here, and then we'll go back to where we were with Cornelius, where he left off. See if I can get this to work. There we go. Most people think that archaeologists are like Indiana Jones. They're out for fortune and glory. They're always out after gold, like Agamemnon's mask here, and or digging around in wonderful temples and things like that. Well, actually, what archaeologists do is they dig up garbage. This happens to be garbage. It's 800 years old. It was thrown away by Hohokam Indians just outside of Tucson. Well, that's what most archaeologists deal with, is this old garbage. But there's some of us who kind of made the connection between the old garbage and new garbage. And this is our database. We're called garbologists. And we do true garbage work. So, and we have no lack of data. Well, this is our unit of study. Instead of digging little holes in the ground, we pick up people's garbage. We put it in little bags. And in fact, we do this all around Tucson. We've been doing this, by the way, for 20 straight years, 6 days a week. And we randomly select households from different census tracts so we can get the socioeconomic variability of the city. We take this back to our facilities at the university. Everything is hand sorted out, and every individual item is recorded in great detail. We even record the brand, the type, the material composition of the packaging, how much was in the material. We weigh any waste that was there. We have an incredible amount of data. We have millions and millions and millions and millions and millions of items recorded now. So we have a really unique kind of database. Doesn't exist anywhere else in the world. And you may wonder, why in the world would we go out and do this? You know? Well, the reason we do it is we want to find out what people do. And you may say, well, why don't you just go ask people what they do? What do they eat? What do they do around their house? Well, the reason is, in the numerous studies that we've done for the USDA and other people, is that there's a big difference between what people remember and report doing in questionnaires and things like that in interviews and what they actually do. Because we've done studies where we ask the people, do the standard questionnaire information. We do standard types of work that the USDA and other epidemiologists do on food intake, and we took their garbage at the same time. And we found a great big difference in this, so that there's a big difference between reported and actual, what people do. Just give you a few examples. This family, this is not unusual at all, reported using fast food twice in this 1 week pickup. There happened to be 12 different kinds of fast food in this particular pickup. It's not an unusual event, and yet they very truthfully, and their memory actually had recorded only 2 times. They're not lying to us. That's what's interesting about it. They're not lying. I won't get into the cognitive psychology and other areas you have to get into to explain what's going on here, but just take my word for it.
How do you know that their children didn't have a party and all the neighborhood teenagers came over with all these things?
Because in the interviews, we ask them those kinds of things, too. We keep really close track on these people. What's interesting, the only time they really ever change is right at the very first, because we have to ask them if we can pick up their garbage. And at first, interesting things disappear from the garbage, like the alcohol bottles, you know, illicit drugs that later will reappear into the garbage. But after about 7 days, it all changes back to where it was. And in fact, what we've done in these studies, we collected 5,000 households of garbage, put it all back, waited to get the permission of the people, then turned around, and those that we had garbage before they even knew they were under study. We had garbage after they were under study, and then we followed them for 2 months straight. And it's really interesting because even those that do change, it's a few minor items, they'll change in the first week, and then they'll change back to their normal pattern after about a week. So then we know have good data where we're looking at people's actual behavior versus what they remember and what then they in turn report. This is another example of a study we've done where you look at, we looked at household hazardous materials in this. On the left side, you can see that this is what people report they use. On the right side, this is what we actually found them using in garbage. They have no idea pesticides isn't even in their mental image of things that they use. They way over-report motor oil. I'm just giving you different examples of this. This is one where if you were going into an epidemiology study and you were wanting to look at caffeine use, I just threw this together, randomly selected 12 households out of a data set of ours for you. And the red is the garbage, and the yellow is the reported amount of use. This is from soda. If you were to calculate caffeine from soda, you'd probably be pretty close. People tend to underreport soda, probably because of some negative attitudes towards soda. but you wouldn't be too far off in the overall caffeine use in the population. Now let's look at caffeine use from tea. People way over-report their use of tea by about twice as much. So if you were calculating caffeine consumption among the population, you were calculating tea, the effect would be you'd be finding about twice as much caffeine intake from tea than they were actually doing in their garbage. Now, here's coffee. As you can see, people report hardly any coffee use, as you can see by the yellow lines, and then you can look at the garbage and see how much coffee they're actually drinking. The fascinating part about this is they're not lying. Their memory actually records this information. I really don't, later we can talk about it, I'll be around this afternoon, about why this occurs. And in fact, I've got some papers that will soon be coming out. I'm doing work with cognitive and behavioral psychologists and with some other people in sociology so we can get a theoretical explanation for what this is occurring. But overall, if you were to study caffeine and use questionnaire data, you would underestimate caffeine use by about 40 to 50%. And that's not a bad underestimate compared to a lot of other things you could be studying. Now, why does this happen? Well, it has to do with values, attitudes, beliefs that people live in. We live in a cognitive, created reality. We have to because we're human beings. We have to make sense of everything around us. And we take into account all the cultural and social aspects in terms of how we live every day. So when we're asked what we do, we don't really report what we actually do because it was never recorded in the memory. What we report is an expected paradigm of our behavior based on how we identify ourselves as an individual in this society. Because so if we identify ourselves as one kind of person, then we're going to report doing certain kinds of behavior. A great example of this was all the studies on recycling issues in the past have looked at how people, who recycles and what all that goes on. Well, in the questionnaire information, it always was people with higher incomes and higher education were the recyclers in the society. Well, when you looked at the actual garbage and you checked out who was recycling, there was no socioeconomic variable relationship to recycling. It was randomized throughout the society. And the difference in what was going on was that people who are higher educated and people who have higher incomes are supposed to recycle. They're supposed to be environmentally concerned. They're supposed to do those things. So they actually create these memories, and they're actually a created memory of what happens and what they were actually doing. One of the big things that really affects is health values, what people see as positive and negative in terms of health. This can really affect how people will report what they use as opposed to what they do. Now, the interesting thing is, this is a group of Earth people living up in Idaho. In fact, that's me on the right side back in my old Earth days. And these people will report doing something very different than this, who happens to be my deceased ex-mother-in-law. And so they're going to report something very different. But the fascinating fact is when you look at their garbage, they act almost exactly the same. They're almost exactly the same kinds of behavior. Yet you're going to get extremely different reports of behavior from these people. So that's one of the other fascinating facts that goes on. Now, just to show you a little bit about how health value affects things, this is things that foods that are over-reported, and these are the percentages we come up with over the last 20 years of research. Cottage cheese is over-reported by 311%. Diet soft drinks are over-reported. You notice that most of the things are things that people have positive attitudes about, Except there's some interesting exceptions. If you look up here, there's, where is it? Butter's in here. Butter's over-reported. Well, that has to do with older people in the population who still have positive attitudes about butter in terms of socioeconomic representation because of World War II, when butter was in great short supply. And they have really positive attitudes about it. Hamburgers also tends to be over-reported, which is kind of interesting. So there's different attitudes mixed in here, but there's a general health issue that's going on and what's healthy for you and what's not. Things under-reported. One thing, remember, you can over-report thousands of percent, but you can only under-report 0. So that kind of looks a little different when you look at it. But things under-report tend to be things that people view as negative, bacon, at least what they're told is bad for them. Bacon, chocolate, candy, and so on. But it's not always consistent, but there tends to be that kind of difference. Now, this is why we use garbage data for studies. in different things rather than interview data. And we're trying to get this information over to other people in medical research and epidemiology that we need to do garbage data along with other kinds of data, including questionnaire information, so that we can kind of get a better perspective on what people are actually doing. And it's what I call the difference between actuality and reality, because reality is a creation. Okay? Well, now let's go back to where we were when Cornelius left off. Corny came to me and he showed me this graph, and I go, that's really interesting. That's not what I understood and what believed at the time. I always thought that fluoride decreased tooth decay. I'd always been told that, you know, in the educational stuff. So I found this very interesting. Well, we'll go back to here, and he had this nice little list that he showed me, the things that had come back where people said that these were the causes of tooth decay. Well, it just so happens in Tucson, we have this fantastic database on garbage. We happen to have these fluoride levels, different fluoride levels, as we were telling you, that come from the water. We've got the high area here. There's a medium band when you actually calculate it and you go and you check and cross-check it against, you know, water in the household. There's a big medium band here, and then there's a very low levels like 0.2 or lower out in this area. And we happen to have, within Tucson, all these different census tracts throughout the whole city where we've collected garbage for 20 years from random selected households. So it's quite an interesting database. So what we were able to do was take these different information and put together a whole bunch of information that we're going to analyze. At the top, you see garbage measures. We actually measured home consumption of milk based on our garbage data. We used a brushing rate, which we based it on the amount of toothpaste people use. Because we calculate the toothpaste, we weigh the waste, we know how much toothpaste is being used in the households. We looked at sugared soft drinks, and then our sugar intake we broke out into 4 different categories: bulk sugar, pastry, candy, and ice cream. So we're able to look at sugar consumption. That's what we got from the garbage. We had school data, wonderfully provided by Jeannie Circa, and the fact that the TUSD, Tucson Unified School District, has been collecting incredible amounts of information on tooth decay. We had percent DMF in all the schools with all the children, like Cornelia was saying, 26,000 students. We had milk consumption in the school. We know how many containers they're drinking in each school. We had how many people were participating in free and reduced school lunch programs. We had school-administered fluoride programs, the Swish and Spit program information on all the different schools in Tucson. And then we knew the percent Hispanic in the schools, as well as the census information on this percent Hispanic, census information on household income, and census information on education within the households. And then we had from the city of Tucson the fluoride levels that were represented throughout the city, which we did both from the well data and from the household data. Now, the information we actually used in this study was the amount of fluoride that we calculated actually out of the water in the households, since we felt that it all related to the same thing. You got these high, medium, and low areas. Okay, quite a database. Nobody else has this anywhere else or could create it. Take them another 20 years to create this kind of information. So it's really interesting. We, by the way, happen to be way out here. This is looking on downtown in the Catalinas. So we undertook the study and put all the information together. Now, in this study, which is somewhat limited, we only used 7 study areas because we had to correlate school areas with census information, with our garbage data information, and all together. So we were able to select out 7 different areas in the city that we were correlating all this data together. And we ran the information on the decay, missing, and filled from the school data with the fluoride, and we found the same thing Cornelius had found, that as the fluoride increased, so did the amount of tooth decay. It increased. So we confirmed what he had found. Then we started looking at other areas. This happens to be income, and as the income decreased, the amount of tooth decay increased. Typical thing that's been traditionally shown over and over again in tooth decay studies, that income is related to tooth decay. Income drops, tooth decay goes up. We also found that same thing that had been found typically is that as the educational level dropped, so did the amount of tooth decay increased. So we found that again too. These are real traditional types of findings. One of the things, though, that you have to look at here is we have two very separate populations represented in this data. These three areas are very high Hispanic areas. There's right around 70 to 100% Hispanic in these areas. And these other areas over here that are in the other areas are non-Hispanic populations. Well, we looked at other things like ice cream and pastries. The dashed lines is pastries, and this is ice cream. And what was interesting, we found no relationship to the amount of caries and the consumption of pastries and ice cream. Ice cream pretty much was the same across all the populations. Pastry consumption was about the same. And then we looked at free and reduced school lunch programs. And as the participation in free and reduced school lunch programs increased, well, the tooth decay increased also, which was not very happy by the CDC with us about this kind of information. But again, the participation in the school lunch program is an artifact of the fact that our Hispanics are the lower income area. And everything kept pointing back to Hispanics, you know, Hispanics versus non-Hispanics. It's just an artifact of the fact that they're Hispanic, okay? Because they're lower income, they participate. But then when we kept looking at the things that generally are traditionally shown as tooth decay, causes of tooth decay, it didn't bear out. We looked at milk use. It's about the same in our population. I know this graph's hard to read, but just follow the lines. And regular soda use, which is sugar soda use, about the same across all of our populations. We didn't see any relationship to that to tooth decay. And this one looks kind of strange. This is flossing rate, by the way, down here. The floss that was in the garbage. We have other issues with floss, like goes down the toilet, goes in other places. But basically, our flossing rate's so low among any of the populations, it has no relationship to tooth decay. So we just basically blew that off. But it was kind of interesting when you look at candy use, which is the solid line. Candy use is highest in the non-Hispanic areas, and the Hispanics don't use a lot of candy. But then the opposite direction is this dashed line, which is bulk sugar. Hispanics use a lot of bulk sugar, and non-Hispanics don't use much bulk sugar. But when you look at the overall sugar intake, it's almost the same between the two. It's just they're using it differentially, you know. But it was interesting because here you look at this, as bulk sugar use increases, so does tooth decay. But as candy use increases, tooth decay declines. Yeah, so we're getting these opposite kinds of directions. Well, we're trying to figure out, well, what's going on here? Well, the one thing it keeps going back to is Hispanics versus non-Hispanics over and over and over again in all this data. We happen to do it for the 1980s. We did another set for 1970s. So we have two separate decades analyzed. We found almost the exact same results in both data sets. And so what we begin to realize is what we're dealing with is the difference between Hispanic versus non-Hispanics in the population. And this shows you this is the percent of Hispanics in the schools, and you can see it's almost just perfect correlation, even though we're dealing with this few data points. We will hopefully in the future be able to go up to 16 different areas as part of our study, but I know we're going to find the exact same patterns going on. Well, we also did a study where we broke out Hispanic versus non-Hispanic, and I'll get to that in a minute, but what we found out by combining everybody together, related as expected, bulk sugar related to higher tooth decay rates, pastry related to tooth decay, income, education, and Hispanic versus non-Hispanic related to tooth decay rates, which were traditional things that had been found in other studies. In the opposite direction, we found that school fluoride programs increased participation. You got more tooth decay. The more water, more fluoride in the municipal water, you got increased tooth decay. More milk use in school, you got increased tooth decay. And then candy, the more consumption, increased tooth decay. We didn't find any relationship to home milk consumption and tooth decay. Soda, ice cream. We also checked out antibiotics, by the way, but they're very low use throughout all the population, but we didn't find any relationship to tooth decay. And then the brushing rate we didn't find related to tooth decay. So what we did was we broke out and did analysis on Hispanics versus non-Hispanics. Now, when we did that, what we found was some really interesting things. Among the Hispanics, their overall consumption of sugar didn't relate to tooth decay. Their milk consumption didn't relate to tooth decay. The brushing and flossing didn't relate to tooth decay. The antibiotic use didn't relate to tooth decay. One thing related to tooth decay, and it's down here at the bottom, And that was the amount of water was the amount of fluoride that was in the municipal water supply among Hispanics. What was interesting when we broke out and looked at the non-Hispanics, we found all the traditional kinds of relationships. Candy consumption increased. Well, they got more tooth decay. Not so with the Hispanics. And water in the fluoride in the municipal water supply increased. Their tooth decay went down. The Hispanics, it went the other way. Okay? And then like participation in school lunch programs, because we did have some poor areas with non-Hispanics. And we found that as their participation in school lunch programs went up, their tooth decay went down. But for the Hispanics, it was the opposite. So something is going on very differently here in this population. In fact, what we think it basically is that Hispanics, for some reason, are very, very affected by high levels of fluoride. And non-Hispanics seem to get some benefit from it, at least in this population here in Tucson. Now, our Hispanics in Tucson have been here a long, long, long time. They founded the city. They've been here about 200 years. And the populations we're looking at are very old populations of Hispanics, large gene pools that intermarry. So what we think is happening is that we got a gene pool here of Hispanics who have negative reactions to fluoride. And we don't know what the mechanism is. That's one of the things we'd like to eventually find out. Because it doesn't make sense. If you increase the fluoride, you should see some decline in tooth decay because it hardens enamel. And we don't know what it is. Maybe it hardens enamel too much. Maybe we get microfissuring problems in the teeth and so on. We don't really know. But we do know that this relationship occurs. Now, we've done some other studies where we looked at other cities around southern Arizona. And we found the exact same thing in historical data dating back to the late 1940s and early 1950s, that in the cities where there's low fluoride, because everyone relies on well water here, the cities where there's low fluoride, Hispanics have very low tooth decay rates. In the cities where there's high fluoride levels in the well water, they have high tooth decay rates. So we found it in other areas throughout southern Arizona, like over in Yuma and different areas. So basically that's what we come up with. We don't know what the mechanisms are that are creating this. All we know is that when you give these people fluoride, boom, the Hispanics fluoride, they tend to get higher tooth decay rates. And the Hispanics in Tucson who are in the lower fluoride areas have much lower tooth decay rates than those in the higher fluoride areas. So that's where we're at in the study right now. We want to increase this to a larger study. We also want to look at overall fluoride consumption, because one of the things we can do with the garbage project data is we can look at the total diet of households, everything that they consume. And there's fluoride in all kinds of stuff. From the soda you've got, it's got very high levels of fluoride in it. And different kinds of products do. We want to look at overall fluoride levels. We also want to include another area, the different kinds of starches, which we haven't included in this study, but we can go back and analyze this, and we want to eventually look at it. The other thing we want to do is find out what in the world is the mechanism that creates all this. Because we haven't figured that one out yet, too, but we would like to be able to analyze the teeth from the children and so on. Yeah?
Is there a difference in fluoride, sodium fluoride, as opposed to the natural calcium fluoride?
Cornelius, you want to answer that? Did you hear it?
Yeah, well, the amount of fluoride is essentially F minus the ion itself.
Does that answer your question? Yes.
Okay. And
So the question was, is there a difference between the sodium fluoride that's in the municipality's water and that of the more natural occurring calcium fluoride?
Okay, once again, the city has no artificial fluoridation. This is all natural. And so the fluoride, we only measure fluoride as F minus. The water has both calcium and sodium in it.
Well, those of us that live in communities that they do fluoridate, they usually use the sodium fluoride.
Yeah, the most common one, the most common fluoridation agent nowadays is the hydrofluoric acid. But before that, sodium fluoride was used. Yeah.
one of the things, though, we're proposing right now, and after I went and did a background research in this paper that we did and looked at a lot of the other studies that have been done, and, you know, looking at the mixed results that you normally see in those studies from one study to the next, and even in the same study when they're talking about different communities. And I think what we may be looking at is differential reactions to fluoride levels among different kinds of gene pools. And this kind of points to it in this study, where we've got a gene pool of Hispanics who are responding very negatively in tooth decay, and then we've got, non-Hispanic population who seems to respond in the traditional way, that's been presented at least. But then you go back and look at all those studies and you find really mixed results, and I think we're dealing with, we may be in all those studies looking at different gene pools have different tolerance levels, and depends on what you're looking at. Yeah? Yeah, and so,
much more chemically active than the other.
yeah, and we don't, we've got to look at this in terms of the population. That's one of the things we want to go back and look at these populations, try to figure out what's going on. Because now I think we've got enough evidence, because nobody's going to have this kind of data in one place. This is it can't exist. It's going to take 20 years for somebody to collect this kind of data, and let me tell you, it's cost a huge amount of money and time for the garbage project to put this data together. And it's a unique database, and then we're really unique in our well water study here, and we're unique in the fact that we studied the children. All the children have been studied in this city for so many decades, that this kind of leads us into the situation where, now we've got ability to look at the mechanisms and in this population. We also have a lot of other studies that have been done on this population in Tucson because of other issues around water. We have a lot of epidemiology work in other kinds of diseases too. So because we've had problems in the southern part of the city with TCE contamination and other things. So there's been a lot of information collected on the populations. So we can go back and start beginning to correlate this and try to see what we can get out of it. But like I say, it's unique. You can't go anywhere else and get this kind of information. It's what we want to do, like I said, is also begin to look at overall fluoride intake. We have the ability to do that over the last 20 years and see actually what the relationship is to about anything we want to study. So Tucson's going to be real interesting over the next few years as we begin to get into these kinds of studies and develop a funding base for them. Any other questions? Yeah. Have we looked at gender differences? No, we haven't. We haven't. We're dealing with, like I said, study areas where we're dealing with blocks of populations, and we can get ethnic differences out of those because of the differences, different concentrations of ethnic groups, but we don't have gender groupings occurring within these populations, so we haven't been able to look at gender with this. Any other questions? Yeah.
Yes, I'd like to make a statement. You made a statement that fluoride makes the tooth harder. I would like to disagree with you on that statement. Everybody that's done any work with teeth that were formed in areas of high fluoridation knows, any dentist who's prepared cavities in these teeth knows they are much softer. And the reason for that is the tooth is composed of calcium fluoride instead of calcium carbonate, which is softer than calcium carbonate. The reason for the supposed lesser decay is that calcium fluoride is less soluble to acid. That's at least excuses. There is another bit of evidence on this side, and that is that physicians have been giving patients with hip fractures or leg fractures fluoride to harden their bones to make them less liable to fracture. Actually, what they found is they're more susceptible to fracture. And that's because they're softer, not harder.
Well, that's what we got to find out, is look at this. Well, in this population, if we can get it together, we can actually look at actual teeth coming from dentists and examine those teeth from these different populations. That's one of the things we'd like to be able to do. And we could do this in a not that long-term study, but maybe in a couple years of analysis, we could do that by taking teeth that have been removed, and using those for part of our analysis, because we've got to figure out what's going on. We just don't know for sure. We need to be able to examine it. Any other questions? Yeah.
I read an article stating that Japan has a situation with their populace where they need half of the dose that an average American would if they get up to what the Americans have, the doses they get in the case, like with Japan.
Right. If you look at the Japanese studies, what they found there is that they get declines in tooth decay when they go up to about 0.4. When they go over that, the tooth decay starts to increase dramatically. In fact, it becomes exponential, such that when you get up around 1 or 0.8 that's recommended in the United States, they're looking at twice, sometimes 3 times the amount of tooth decay that they would if they were fluoridating at 0.4. So, you know, here we've got another example of a gene pool, because you've got a truly segregated population, you know, of Japanese. And then even in their studies, they find differences in different gene pools up and down the island. So they've got some areas where they can go up to 0.8 and still get positive effects. In some areas, they can't go over 0.1 without getting an increase in tooth decay within their own populations. But then they don't have a tendency to move around. They have the same thing here, that they've got inbred genetic populations within certain areas of the islands. So yeah, the Japanese studies almost show the same thing, in my opinion. And in fact, I point that out in some of the writings that we're putting together. Any other questions? Okay. If you have any questions about anything, or one of the things about the basis for the difference between what people actually do versus what they report, it's kind of an interesting question. You end up having to get into psychology. It's a mix of psychology, anthropology, sociology, and different kinds of areas. So you have to mix all these sciences to begin to figure out what's happening and theoretical basis for it. But it's becoming, one thing I'll point out is it's becoming a new science. What me and a few other people are trying to do is start a new science of behavior that will add this as a database to all the kinds of studies we do, in addition to the questionnaire information that we traditionally use, because the questionnaire information gives you a lot of neat kinds of information. It just doesn't tell you what's actually going on in certain kinds of behaviors, like food behaviors, brushing your teeth, and so on, these kind of mundane everyday behaviors. So we're beginning to push this in different areas. In fact, I'll be at Cal Poly in 2 weeks talking there to engineers about the actuality versus reality distinction. And so this is beginning to spread, and we'll be able to get it going. But I think it could form a good database for us to really work in epidemiology and begin to look at other things too, like cancer rates and different cancers and so on. Yeah?
Did you find any difference in the rate of fluoridated toothpaste in your garbage over time?
He asked if we found any difference in the rate of fluoridated toothpaste over time. We haven't looked at it from the fact of whether the toothpaste is fluoridated or not. We have that information, but that's exactly what we want to do. We want to look over the last 20 years in this population here in Tucson, and we want to look at the overall fluoride intake through all their food consumption and calculate it, because one of the big things the National Research Council has said, even when that, I think it was about 2 years ago, they came out with an article talking about fluoride and the different negative effects that they knew at that time about it. One of the things they said is that the big question is, we don't know how much fluoride people take in. Well, we can tell them how much fluoride people are taking in, at least get a good, solid, educated guess for general population, at least here in Tucson, and that'll give us another idea in other populations. And we'll probably be, we could give the amount of fluoride intake per person per day, and over the last 20 years, and we can look and see what's increased and decreased. Yeah?
Is Molly and the rest of the city council aware of these factors, and if so, how would they justify fluoridating water, because there's no way that they can collectively deliver to each different population or Hispanic, Japanese, Anglo, Negro?
Well, Cornelius could answer better if they're aware of it, but I'm sure they are aware of it. Corny would make sure of that. But the decisions that are being based on what to do with the populations aren't based on data. It's based on politics and general perceptions in the population. The one reason they voted through, I know I've got to get going here, but the reason they voted to go on and fluoridate the camp water was a basic decision, because in the population, the general population overall, it's viewed that they would be abandoning the Hispanics, the people that are supposed to be helped the most by fluoridation, you see. And so you're battling this political perception versus what the data is beginning to show us and tell us out of this kind of information. I can take only one more quick question. Yeah. Cornelius, you want to answer that?
Chicken broth. Fish. Coca-Cola.
Sodas have a lot of Soda has to have a lot of fluoride. But we can look at that. There's tea, you know, but there's a lot of list of them, and we could put that together because we know the actual consumption rates in the population. So we could do that if we wanted to. Okay, I better get going so you can get around the next speaker.